So this is the presentation on essentials of medical records management, and this is the scheme of presentation that we will cover. We will talk about what medical record is and how it is relevant to our requirements, and especially from the hospital management point of view. What are the attributes of good medical records? The record retention policy, the essential functions of the medical records department in the hospital, the functional activities in the medical records department, and what should be done for the medical record review. So let us look at these things one by one. The medical record is a chronological documentation of medical treatment and other healthcare delivered to the patient by the professional members of the care team. So here, if you look at each word is important. It is documentation. It is chronological in nature. That means it is in the order of occurrence in time. It is record of those activities which are carried out by the professional members of the care team. So when we say professional members, we are talking about the doctors, the nurses, and the physiotherapists, and other professional therapists who may be involved, for example, a dietitian or a nutritionist. But we are not talking about the assistants, and we are not talking about any other category of staff in the hospital. So only these people are the ones who are permitted to do the endorsement in the medical record of the patient. This is an accurate and prompt recording of team's observation. A team is the care team of the patient. So the team's observation about the patient and patient's medical progress and the results of treatment. I think this should be easy to understand. It is a means of communication among health professionals. It is also a legal document and a tool for medical research and training. So I think we understand these components fairly well. So whenever a medical record is generated, it is also seen by other professionals, and that is how the patient information is communicated. In the course of law, whenever there is a medical matter, the medical record is the only document that is necessary for taking a decision. And it is also the primary means of evaluating the quality and appropriateness of medical care rendered, as well as the source document for statistical use in research planning and budgeting. So medical records are also used for quality assessment, and that is the reason why we do clinical audit. So all clinical audits that we do, except the ones which are either concurrent or prospective in nature. In fact, even for these kind of audits as well, we are looking at the medical records essentially to see what activities on the patient have taken place and the ones which have not taken place correctly. And finally, the medical record is also the original source document for financial activity involving the patient care. And here we mean by this is that whatever the financial activity takes place in terms of billing because of the for the care rendered, that also comes from the medical records. It is important to note that the medical record is the property of the hospital. It does not belong to the patient, and it also does not belong to the doctor. It belongs to the hospital. So neither the doctor nor the patient can remove these records from the hospital. And it is typically composed of various forms, various formats, which are filled by nurses, doctors, and other care providers. And they are clubbed into one set or one bunch, which is called the medical record, or also known as patient file, or whatever name you give it. So this is the inclusions in the medical record, and they are required to be arranged in a chronological manner. So as the care happened in terms of time, they are supposed to be recorded. So what are the attributes of a good medical record? So this is what is necessary for us to know. It is supposed to be the accurate record of care delivered. That means what has been done to the patient should be recorded in the medical records. So when we say it is an accurate record, we are talking about how much details are being recorded, what parameters are being captured, and especially if you are aware with the NABH accreditation system or the JCI accreditation system, then you would be aware that the accreditation standards themselves on various at various points demand that certain information be recorded in the patient files. So whether it is the anesthesia records or whether it is the daily assessment and the reassessment records, all these all these add to the quality of information that is captured in the medical records. So it is a good medical record will be something that is accurately captured in the documents of the patient. The second attribute of a good medical record is that the continuity of care is recorded, which means all the events that have taken place are recorded. There is no gap in information, and this is also chronological record. And the last and the most important requirement is that the medical records are handled in a manner which ensures confidentiality of the patient's information. So here, when we talk about confidentiality, we are looking at things like who has the access to the patient's records in the wards. Is it that anybody who walks into the ward can open the patient file, or only some people can open the patient's file? Once the patient is discharged and the record is there in the medical record department, who all have access? Who can ask for a patient's file, and in what manner, and what are the procedures of the hospital to ascertain that the person demanding the information is the actual intended recipient of the patient information? So these are the factors that are included in the confidentiality, and whenever we are working in a medical records department, we need to address these things. The second important component of this, the third point, is the integrity of the medical record. So whether the record is stored in such a manner that the integrity of the record is intact, which means there is no tampering with the record, there is no mixing, so one patient's record doesn't get mixed with the other patient's record, and also that security is ensured. Now, when we talk of security, we are looking at theft and damage by we are looking at theft and we are looking at damage. Now, theft, of course, is something that somebody comes into the department and takes away the record, so that is ensured by having the access control. So you allow only those persons who are authorized to enter the department. Or the damage can be because of elements of nature. So there will be water which can cause damage, or fire can cause damage, or you can have pests which can cause the damage to the record. So medical record has to be preserved from all of these elements of nature as well as from pests. Next, we look at the record retention policy. So in the record retention policy, we have to understand the rationale for it, because nowhere in the statutes or except possibly the NCI ethics guidelines, ethics regulations, nowhere it is specified as to for how long you should keep the records of the patient. So for this, we need to understand what is the reason for retaining a record of a patient. So reason typically is that we need to retain the record for the purpose of patient care. So patient was admitted in the hospital, the records are generated and they are kept. Now, if the patient comes back again after maybe a few months or maybe a couple of years, whether the records will be there for the healthcare providers for their guidance to know what happened in the previous episode of illness. So this is the purpose for which records are retained. The second purpose is the medico-legal purpose. So in all medico-legal cases, medical records are retained because they are the evidence for the medico-legal case that is being decided in the court of law. The next is the legal requirements. So there are a number of legal requirements. For example, the birth and the death records. You have items like the age determination, which are medical matters, and also in the consumer cases, when the records are part of the evidence that are being analyzed by the court of law or by the consumer forum. So again, so the legal, medico-legal, and consumer cases are the reasons for retaining the record. The third important reason is that it is for the purpose of research or for the purpose of academic interest. So all teaching institutions typically retain the records because these records are the source of large quantity of metadata. So meta-analysis can be done using these records. So these are the rationale. The Medical Council of India, in its Ethics Regulation 2002, says that the indoor patients' record are required to be retained for 3 years, and for this purpose, they have also given a format. Now, this is a regulation of 2002. A lot of time has lapsed from since 2002 when the regulation came. So, in the modern hospital-based practice, the inpatient or the records are maintained in a format which essentially contains far more information than what is given by the Medical Council requirements. So this is the guideline. So we retain the OPD records for 3 years, the IPD records for 3 years, and this 3 year is from the date of last visit. The medical legal records and all records which are and which can be used for legal purposes are required to be retained till the completion of case. Now this can be a rather open-ended question where how long you should retain the record. So the answer can be anything from 1 year to possibly long time like 30 years. So the simpler practice for the hospitals is to retain the medical legal case records permanently. This reduces the complexity in the process. And in any case, the medical legal records are smaller percentage of the total records, and therefore it is also possible to retain these. For pediatric patients, the recommendation is that the records be retained till 21 years. And in the next slide, I will cover the rationale why it is 21 years. So the retention period of medical records is influenced by these 3 statutes. The first one is the Limitations Act of 1963, which says that an evidence, if a case has not been filed from the time of the cause of action to the filing of the case, if it is more than 2 years, then the case cannot be filed in the court of law. Of course, the courts are permitted or courts can give waiver to this limit, but the Limitation Act does give a barrier of 2 years. So this is one factor which has to be considered. The second factor is that in the matters of tort, those who are aware, and since it is not part of today's discussion, so we will not be able to discuss it. But I just need to mention that the law is in 2 broad categories. One is called the law of tort, which leads to civil liability, and the other one is the criminal law, which leads to criminal liability. So in the civil liability cases, the limitation period is 1 to 3 years, given in different statutes related to matters of tort. The Consumer Protection Act, which is a matter of tort, has a limitation of 2 years. So 3 years is the maximum period for which a record may be used by the court of law. Now, if you look at the medical record, the IPD, so if you look at the pediatric record, a person can file a case in the court when he becomes a major. That means the day he attains the age of majority, which is 18 years at present. So once a person becomes 18 years, he is in a position to file a court in his individual capacity. Before that, the case has to be filed by the guardian or by the parents or by the legal guardian of the person. So in the instance where a 18-year-old person can file a case, and this becomes a matter which is taken up by the court, this will require production of medical record, and that is the reason 3 years, because 18 plus 3. So a birth record is kept till 21 years. And at the 18 years, the person can file a case in the court of law, and then the records are. That is the reason why records have to be retained for that period. So the final recommendations go like this: OPD and IPD 3 years, medical legal case records for 30 years or till finalization of case, which in many instances will be very difficult to figure out when the case has been finalized. That is the reason a lot of hospitals practice as a period of 30 years. And pediatric records for 21 years, 18 years is the age of majority, and 3 years is the maximum time permitted under the matters of tort in the law. So that is 21 years. So next we come to the essential functions of the medical records department, and here we are looking at the OPIP registration, the preparation of statistics, filing of records. Typically, the registration process is part of the MRD. However, many hospitals have organized it differently, and it is not necessary that you stick to this particular way of working. It is also possible that you have a registration function independent, but a common practice is to have the the registration being controlled by the medical records department. The preparation of statistics, filing and maintaining the records, and the retrieval of records. So these are the essential functions of the medical records department. We also need to have the coding and indexing according to the latest ICD version. ICD is the International Code of. Someone has a microphone on. Can you mute the mics, please? So indexing and coding according to the latest ICD edition is the requirement which is fulfilled by the medical records department. And the last requirement is the dissemination of medical information. So the medical records department generates a lot of statistics, the length of stay, the diagnosis-wise summary, and many other bits of information which are essential for the hospital management point of view and also from the patient care point of view. So these information are also generated and also disseminated from the medical records department. Now, what activities take place in the medical records department? So typically, you have a situation where the patient record is generated in the wards, and after the patient is discharged, the patient file is either carried to the medical records department or the patient file is collected by the medical records department. Either way, the file reaches the medical records department. That is MRD. And in the MRD, what activities must take place on that particular file is the one that we are going to talk about now. So first we have deficiency check. Now this is typically done by using a checklist. So most hospitals have a checklist for medical records where the staff in the medical records department, they use that checklist and see whether all components of records are available. So this is a deficiency check. Now in the deficiency check, you not only check that all the records are available, you also check if there are any missing pages, because typically the progress notes and the case sheets and files are in loose sheets. So it is possible that in the wards, sometimes the pages go missing. So the medical MRD staff has to see that all the pages are there. So these pages, this is checked by seeing the date and the time and seeing whether all the sheets are available. The MRD also needs to check whether the date, the sign, and other important information is captured in the medical records or not. Then there is a requirement to do the indexing. Typically, patient indexing is the one method which is used, but you can also do disease indexing as well as physician indexing, which basically means that you are allotting a number to each record which will identify the patient or the disease group or the physician, and in many institutions you will find that all three indexings are being done. Patient indexing is by far the most common, where each record has a patient index or the UHID number, or sometimes a separate MR number or the MRD number. So this forms the patient index. Then coding is required, and the current standard for coding is ICD-10. In a lot of hospitals, you have a practice of tagging. So you do the color coding of these. So we have colored files. So you see that all the medical files, medical legal case files are in the red colored files. The pediatric records are in one color. So like that, the color coding can be done. This is typically practiced in large hospitals. In the smaller hospitals, it is not necessary to have a color coding. So long you have a patient index in place, it is acceptable. Then we need to have a filing of the records, and in the filing we have many filing methods where the records are kept. So this can be filing. The filing can be done by serial order, which means you have the UHID number or the MR ID number, either number which you use, and you just store the records in one serial order, in one running serial order. So you have the cupboard or the lockers or the shelves, and in the shelves you put the records one by one, like that in the order of the number. The other option is that you use the terminal digit system, and there are many other ways of filing the records. You can use terminal digit, you can use month-wise records, so they can be done. Now, in the terminal digit system, what is done is that in the UHID number, you have a number which is allotted to each patient. Now, in that number, the terminal digit, the last digit is used. So all the UHID numbers which end with number 0 are kept in one place, in one order. Then all the ones which end with 1 are together. So this is a system. Some people find it complex to use, and they simply use a serial order system, which is all easy to understand and also easy to implement. The next functional activity of the MRD is the retrieval, and for that the MRD will require a proper retrieval system in place. Now, what is the retrieval system? So, if you have to take out a file from the MRD, you have to have a reason why a file is going out. So, typically a requisition is required. So, the person who wants the file will give a requisition. Based on that requisition, the MRD in charge will take a decision whether a file can be given or not, and then the file is taken out from its place in the shelves. From the location where the file has been taken out, you put a tracker or a marker. A marker is nothing but a kind of a hard board or a hard sheet which is colored differently, so that you know that these files have been taken out from the shelves. It simply shows the location from where the files have been taken out. And then this file is issued, and the person who's requisitioning the file gives his signature on the register, and the file is given. Now, we are not getting into the nitty-gritties of this particular process, but suffice to say that the retrieval is a function of MRD. So, MRD has to find the record and also give it to someone who is authorized to take that record. Next, we come to the medical record reviews. So, this is the last item in the discussion today. Medical record review is the requirement of NABH standard, and in the IMS 7 is the standard where the record review figures. In the JCI as well, in the JCI accreditation system also, you require to do the medical records review. Now, in the medical records review, we need to take a statistical sampling. In fact, many times this is also called the medical record audit, and this has to be done following the statistical principles. So we take a statistical sample. The simplest method to do this is to use the table given in the NABH guidebook. That table we have also shared in the during other occasions in the other presentations, when we talked about the prescription audit and the clinical audit. So we have shared that table. It can be given again. I mean, I have not included it in today's presentation, but it can be given. It is easily available. So that table tells you that what is your population size, and based on that population size, what should be your sample size. So this is what is a statistical sample. The other method is that you use many of these sample calculation formulas which are available online, and you can use those formulas and also calculate the statistical sample size. Next, we need to fix the parameters based on which the audit can be done. The essential parameters as per NABH accreditation system are timeliness, legibility, and completeness. So if you are doing a medical record audit or a medical record review, these three parameters must be included: the timeliness, legibility, and completeness. You can add more parameters, but if you do not include any of these three, then this becomes an observation in the NABH assessment. Both active and discharged patients have to be included in the medical records audit. So active means the patients who are there in the hospital today, and discharged, of course, are the ones who have gone home. So we use both these types of patient records, and this has to be done by an identified individual. So typically in the hospitals, you have in large hospitals, you have a medical records committee. So this committee can say that this one person will do the audit. You can also put the MRD in charge for doing the audit, or anyone else can be assigned. Someone who knows these principles of doing the audit can be can be given this responsibility. So this has to be identified. So there has to be a person who is going to do this. The purpose of medical record review is to list and discover the deficiencies in the medical records. And what kind of deficiencies we are looking at? We are looking at deficiencies in terms of these parameters, the timeliness, legibility, and completeness, and any other parameter that you may have added. And once we have found the deficiencies, like in all other audits, we need to have a plan for corrective action and for preventive action. So this is about the medical records essentials. If there are questions, I'll be happy to take. This presentation will be given to everyone who is given the email ID, and we will send it. Any questions? A simpler topic, but it is relevant to all of us in our daily practice, and that is the reason we thought it will be a good idea to revise this.
Sir, it is seen usually for 5 years, people are keeping records in approximately all hospitals.
Madam, as I said, there is no one guideline available. Maybe you have seen that the oncology hospitals store a record for a very long time, because the oncology patients have a very long follow-up. So similarly, you can decide what time frame you want to use. There is no hard and fast rule. A lot of people use the Government of India Ministry of Health and Family Welfare notification of the medical record retention. That also can be used. It is actually a lot of flexibilities available to the hospitals. What is important is that, considering your own requirement, you see for how long you want to store the records. The Medical Council of India regulation is 3 years. So I guess you will be able to make your own policy for this purpose.
Right, sir. And for medical legal, it is advisable to keep for these many years, as you suggested?
Madam, the requirement is to have the records available till the duration of the court case. Now, the problem for the hospital management is how to know that the court case is still going on or it has been completed. How do we know that?
Okay.
The court will tell the hospitals. The patient will not, or the family will not come back and tell the hospital. So people use a simpler method and say, okay, you hold the record for as long as it is practical. So a lot of people store it permanently. You can store it for 30 years, which is reasonable. I mean, longer than that, possibly it doesn't make sense. I mean, this is pure on the on common sense. It is not based on any statute. There is no law which says for how long you should store the medical legal records. But the logic is that the record is the evidence which is used in the court of law, and the evidence will have to be preserved till such time there is a case in the court of law. Is that? I hope I have made it clear.
Absolutely. Sir, thank you so much. Thank you.
Sir, AK Singh from Sraf Hospital, Daryaganj. Is there any guideline to discard the record? How to discard?
Okay, so record destruction is something that has to be carried out after the retention period is complete. So if you have a system, let's say you are holding the record for 5 years, for example, then every 5 years, every year you will be removing the records which are older than 5 years, isn't it?
Yes, sir.
And the method to destroy a record is that the records, basically after the retention period is over, what is the utility or usefulness of the record? To whom these records are useful? As the hospital has already decided that I don't need these records beyond this time. So the records are useful.
Yes,
so
sir.
The only person to whom the record can be useful is the patient himself.
Yes,
so this practice is there in a lot of hospitals, where they notify in the local newspapers that we are going to destroy records for this period from this date to this date. Anybody who wants the records can come and collect it, or otherwise they will be destroyed. This is one practice which is kind of based on common sense, and it is good practice. It can be used.
Okay,
there is no binding on you to binding on you to notify the newspaper that you are going to destroy the records. It is not binding. It is not stated in any law anywhere. But it is just a good practice that you are holding the records and you are in any case going to destroy it. So if he has a use for it, he can take it from you. That's the logic.
Okay, thank you, sir. And any, sir, regarding electronic record? EMR.
Same thing applies to electronic records as well.
Okay, sir. Thank you, sir.
Electronic records have an added element of confidentiality and security requirements, because if your server is not in your hospital and you don't own the server, then you have to have all these agreements for protecting the confidentiality of the patient information.
Okay, sir. Thank you, sir.
You're welcome. Okay, all those who have asked for the presentation, the presentation will be sent. Any more questions? Any more questions?
Yes. Can I come in?
Yes, ma'am, please.
What is the retention period for patients admitted in a palliative care unit?
Ma'am, it is not defined anywhere. As I said, the records are the property of the hospital, and you need to hold these records as long as you have the use for these records. Now, typically in the palliative care, this is a long-term kind of arrangement where the patients will be under your care for a significant period of time. And in an oncology setup, in any case, patients are with you for a long period of time for follow-up. So the practice which is there in oncology hospitals is that they hold the records as long as for a very long time. I mean, I have, if you look at the example of AIMS in the IRCH in AIMS, they hold record permanently. Similarly, a lot of cancer hospitals hold it permanently. So palliative care also, the records are kept for the duration of life of the patient. So if the patient is with you for long-term follow-up, you will in any case know the outcome, and thereafter you can take a decision whether to hold the record or not. But these are long-term commitments, and for that, the arrangements accordingly have to be there in the hospitals for the records.
And after the death of the patient.
After the death of the patient, ma'am, if you have no need for the record for any research purpose or something, you can destroy the record. There is no issue with that.
Thank you. Thank you.
As I said, ma'am, earlier also, that there is no statutory requirements other than 3 years given by the Medical Council of India. So we are left to our own devices. We have to figure out what is the most correct thing to do. Now, most correct thing is based on the requirements, and the requirements will vary from one hospital to other. I mean, a multi-specialty, basic specialty hospital may not have requirement to hold the records for 10 years. But in a lot of oncology setups, because the follow-up is long-term, so people do hold the records. So it is essentially guided by the requirements of the hospital.
Thank you very much. Thank you.
You're welcome, ma'am. Any more questions, please? This is a subject which generally generates a lot of discussion because of two reasons. One, that there is no clear guideline available. I mean, there is no clear statute available. And secondly, there is so much of variety in practice by different hospitals that the discussion is generated. So that is the reason why I'm asking. If there are questions, then not only we will try to answer, but a lot of people can benefit from those questions.
Can
yes,
I come in?
Thank you, sir.
Supposing,
yes,
you said that after the death you can discard, but supposing the patient dies today and within 2 years or 3 years somebody makes a medical legal case or something, what do we do at that time?
Ma'am, it is like this. In the presentation I covered 3 statutes, the laws which are influencing the duration. So the maximum period in those laws is 3 years. So you can hold it for 3 years, and we will say that it is the hospital's policy that we held the record for the duration of the retention period, and we have destroyed it. Once you have a policy laid down in the hospital, and once you have followed that policy, nobody can find the fault with your policy, because there is no one single standard law applicable on this subject. So you make a policy and follow it; it is acceptable in the court of law as well.
Thank you so much.
I mean,
Thank you.
Just imagine if there was a situation like this, the cases can be opened up by anybody at any point in time. It cannot imply that the records will be kept indefinitely.
Okay, thank you.
You're welcome. So thank you very much. Thank you, everyone. It was lovely interacting and also a very enriching session for me personally. Thank you very much. And you can also look at lot of resource that is available on the Research Foundation's website as well as on the learners portal. The courses are available, and we are in the process of offering more and new courses for everyone's benefit. Thank you, everyone, and best wishes.
Yeah,